Hello guys, this is your Dr. Perry again, taking you in human physiology. So we started looking at the circulatory system. So today we'll be looking at the mechanical response of the heart. So the mechanical response of the heart, you are talking of the actual contraction of the myocardium. Remember, we started by discussing the electrical activities of the heart, and then later on we also discussed the ECG, then the normal rhythm of the heart and the abnormal rhythm of the heart, which we refer to as cardiac arrhythmias. So those electrical activities of the heart will result into stimulating the heart and the heart is going to respond mechanically. So that mechanical response of the heart is the actual contraction of the cardiac muscle cells, the myocardium. So remember, you have two myocardium. You have the myocardium that will form the two atria. So because the myocardium, they have a lot of gap junctions, you find that they can contract at the same time. Then the ventricles, they also have a lot of gap junctions, they can contract on their own. So that response in which the myocardial cells are contracting is called the mechanical response of the heart. So in this circulatory system lecture 4, what are we going to discuss? The first part, of course, we're going to discuss the mechanical response of the heart. And then after that, the cardiac cycle, which is part of the mechanical response of the heart, and then the heart sounds. So you have the normal heart sounds. So this is what we're going to discuss in this lecture. So it means by the end of this class, you should be able to explain the mechanical response of the heart, should be able to describe the details of the cardiac cycle and also the heart sounds. How do they come about? Why are you able to hear those lapped up sounds when you're using a stethoscope? So this is the main point of this lecture that we're having. So let's start by looking at the mechanical response of the heart. This is just the general information. So you have the mechanical response of the heart that refers to the actual contraction of the myocardium once stimulated by the electrical activity of the heart. So once you have those electrical activities of the heart, you're talking of the action potentials. The action potentials will stimulate the myocardium to contract, and then you're going to appreciate the mechanical response of the heart. So there are two things there taking place. You have excitation and contraction. So excitation is as a result of the action potentials. The mechanical part is referred to as a contraction. So the excitation is coupled with contraction. So it means that when you're talking of the excitation contraction coupling, you're looking at the electrical activities that are followed by mechanical activities. That is the actual contraction. Even as we discussed when we are looking at skeletal muscle cells, we also discussed excitation, contraction, coupling in skeletal muscle cells and also in smooth muscle cells. That is also taking place within the myocardium. So for this myocardium to contract, they need a stimulus, and these stimulus are action potentials. So you have excitation, contraction, coupling of the myocardium. That will be brought about because of the action potentials as a stimulus that are stimulating the myocardium. But what you need to know is that these two events, the excitation and contraction, these two activities are not entirely time-spaced as they overlap in their occurrences. Though it's important to note that the electrical events always start. So between the two activities, you're talking of the excitation or the electrical activities and the mechanical activities of the heart. The two things, you find that there's an overlap in terms of occurrence or at the time in which they are going to take place. So there's an overlap in terms of time, but you need to always remember that the electrical are the first activities that will be followed by the mechanical activities. Because for you to have a contraction, you need excitation. So it's called excitation, contraction, coupling. So this diagram here, it's showing you that first you need to have an action potential. So you have an action potential of the myocardium that will be followed by a contraction itself. So it's called excitation, contraction, coupling of the myocardium. So remember, after conductivity of that action potentials via the conductive system into the Purkinje fibers, and the Purkinje fibers are going to stimulate the myocardium. And the myocardium, they're going to fire this action potential that is called action potential of the myocardium. So you can see this action potential. You have the plateau phase here. So you have different stages of the action potential. You have stage 0, which is called depolarization. Then you have a small repolarization, and then you have the plateau phase, and then you have repolarization. Then it goes back to the resting membrane potential. So I hope you remember those stages of an action potential of a myocardium. So during the plateau phase, you have the opening of L-type calcium channels. So these L-type calcium channels are the same channels that are found within the tubular system. Remember, within the tubular system, you have the dihydropydine receptor. Those dihydropydine receptors are also called L-type calcium channels. So due to the transmission of an action potential at the level of the sarcomere, then there will be an inward spread of an action potential into the T system. Within the T systems, they are going to stimulate the opening of the dihydropydine receptor. When they open, you know to say that you have more calcium in the lumen of this sarcotubular system as compared to the sarcoplasm. So calcium will start moving now from the T system into the sarcoplasm. This calcium that is moving into the myocardium will bring about the plateau phase, because within the plateau phase, we say that the cells are gaining calcium, at the same time they are losing potassium. But because they are gaining positively charged ions and they are losing positively charged ions, you find that there is no much change in the electrical potential of these cells. So it becomes straight, which is called the plateau phase. At the same time, the same calcium that is entering the cells can bring about myocardial contraction. This myocardial contraction, you can see here that the contraction is starting. At the same time, the same calcium that is entering the cells can go and stimulate the opening of the ryanodine receptors that are found within the sarcoplasmic reticulum. So on the sarcoplasmic reticulum, we have special types of channels which are called calcium-induced, calcium-releasing channels. So those channels, they have a receptor for calcium. So calcium, when it enters the sarcoplasm, it will go and bind to those receptors, and then they open and allow movement of calcium from the sarcoplasmic reticulum into the sarcoplasm. Then this calcium will intensify now the contractility of the myocardium. So you can see an overlap in time between the action potentials of this myocardium and also the actual contraction that is brought about because of accumulation of calcium within the sarcoplasm. And you know to say, this calcium later on will go and bind to troponin C, the tropomyosin will move away, exposing the binding sites. And then there's interaction between actin and myosin. Okay. So we proceed. So in cardiac muscle cells, like I said, the excitation contraction coupling is dependent on calcium-induced calcium-releasing channels. So within the sarcotubular system, you have calcium-induced calcium-releasing channels that are associated with the sarcoplasmic reticulum. So once the dihydropydine receptors open, then it will bring about influx of calcium. So maybe let me explain from this diagram for everyone to understand. So let's start. So this is the sarcolemma of the myocardium, or the plasma membrane of the myocardium, if you want. Then you have the T system, or the sarcotubular system, that is composed of the T system, or the T tubule, and the sarcoplasmic reticulum on the other side. So this is called the sarcotubular system. So this sarcotubular system, within the T system, you have the dihydropydine receptors. These dihydropydine receptors are the same channels that are referred to as L-type calcium channels, which are sensitive to depolarization. So once you have this wave of depolarization or an action potential that is coming maybe from the Purkinje fibers or from adjacent cell via the gap junction, it will stimulate the opening of L-type calcium channels, the dihydropydine receptors in myocardium. So they're going to open to allow influx of calcium. So calcium is going to enter, and this calcium is going to bind to the ryanodine receptors. Remember, these ryanodine receptors are special types of channels which are referred to as calcium-induced calcium-releasing channels. So they have a receptor for calcium. So calcium is going to bind to the ryanodine receptors, then this is also a channel. It's going to open up and allow movement of calcium. So calcium now will be mobilized from the sarcoplasmic reticulum into the sarcoplasm. An increase in the concentration of calcium will bring about calcium spike, and this calcium will go and bind to troponin C. Remember, the troponin complex is composed of troponin T, I, and C. The C has got a binding site for calcium. So once calcium goes and binds to the troponin C, it will bring about change in structure of the troponin complex. That will facilitate the movement of the tropomyosin to move away from the binding site that are located within actin. So the binding site on actin will be exposed. Now actin will be able to bind with myosin. So myosin will be able to bind to actin. That will bring about hydrolysis of ATP, the power stroke. That will bring about shortening of the sarcomere. This will result into myocardial contraction. Then after contraction, you know to say you need to have relaxation. So relaxation of the myocardium is facilitated by the pumping of calcium back to the sarcoplasmic reticulum. So you have calcium ATPase pump that are located within the sarcoplasmic reticulum membrane. So they are going to pump calcium, and this pumping is against the concentration gradient. That's why you need energy. So it's an example of primary active transport. So it's going to pump this calcium back to the sarcoplasmic reticulum, and some of the calcium will be exchanged for sodium. So you have calcium sodium exchanger that are exchanging calcium for sodium. So because you are gaining sodium, when you have an increase in the concentration of sodium, it can bring about depolarization that can activate this myocardium. So to prevent that, you also have sodium potassium ATPase pump that is going to exchange sodium for potassium. And potassium, you know to say, there are leaky channels that can allow movement of potassium. So once the concentration of calcium has reduced, calcium is going to detach from the troponin C, then the tropomyosin is going to slide back, hiding the binding sites on actin. That will bring about myocardial relaxation or relaxation of the myocardium. So you can see an illustration here of myocardial contraction and relaxation. Contraction is brought about an increase in calcium. Relaxation is brought about by pumping activity of calcium ATPase pump, so that you pump the calcium back to the sarcoplasmic reticulum where it came from. So there are certain drugs that can operate at the level of the calcium ATPase pump within the sarcoplasmic reticulum. So they are going to inhibit the pumping of calcium. So that is going to increase the contractility of the myocardium, because you are going to have excessive amount of calcium in the sarcoplasm. So that is going to intensify the contractility of the myocardium. So you have such drugs that can block the pumping of calcium back to the sarcoplasmic reticulum. Some of them, they can interfere with calcium sodium exchanger channels. So there are different types of these synthetic drugs that can operate in such manner. Okay, so since we're looking at the mechanical response of the heart, so there are certain terminologies that you need to understand before we go in detail. So let's look at definition of key terminologies. So definition of key terminologies. So you need to be able to define these terminologies, starting with the heart rate. So what is heart rate? The heart rate is simply the speed of the heartbeat measured by the number of contractions or beats of the heart per minute. So they are measured beats per minute. So I come again, the heart rate is the speed of the heartbeat measured by the number of contractions of the heart per minute. The normal range, you know, is between 60 and 100 beats per minute, because we said that the SA node, they are firing at a rate of 60 to 100 action potentials per minute. That will bring about the contractility of the ventricles and the atria at least 60 to 100 times per minute. So it is usually equal or close to the pulse that is measured at peripheral point. So you have pressure pulse that you can measure, or you can feel the pressure pulse or at different locations of the body, depending on the artery that you're looking at. So the heart rate should be sometimes equal to the pulse, but sometimes you can have a dropped pulse in case whereby the ventricles are not contracting with a greater force. When that happens, you find that they're not going to stimulate the formation of the pulse wave. So once sometimes you have weak contraction of the ventricles, you might not get a pulse. So it's not always that the pulse will be equal to the heart rate. Sometimes you can have a dropped pulse. Okay, so there are certain activities that can interfere, or they can increase the heart rate or reduce the heart rate depending on their effect on the heart. So you have activities like physical exercise that can result into an increase in the heart rate. You have sleep, decrease in heart rate, anxiety, stress that can also increase the heart rate. Illness, some can increase, some can decrease the heart rate. Then ingestion of certain drugs. So you have drugs that can have a positive effect or a negative effect on the heart. So it can increase the heart rate or reduce the heart rate. Then the other thing that you need to define is the pulse itself. So the pulse, it's a waveform that is felt by fingers and produced by cardiac systole, which travels through the peripheral arterial tree in peripheral direction at a rate more faster than the blood column. So once blood is ejected into the aorta, there is expansion of the aorta because it's now getting inflated because of the blood that is injected in it. So there is expansion of the aorta, and then after that, the aorta will recoil. So the expansion and recoiling of aorta will result into a wave formation. So this wave formation will move along the walls of the cardiovascular system all the way to the end of the arteries. So this wave formation is what is referred to as a pulse. So the surge of blood entering the arteries causes their elastic walls to stretch, but then they almost or immediately recoil. So this alternating expansion and recoil of the arterial wall can be felt as a pulse in any point that runs closer to the body surface. So these arteries that are closer to the body surfaces, you are able to feel the pulse. Why? It's because you have the wave formation that is taking place within the arteries. Then it will start moving down the arteries. So what you need to know is that the wave formation or the pulse, the movement of the pulse, the velocity of the pulse is greater than the velocity of the blood. What you feel when you're taking a pulse, it's not the movement of blood, it's the movement of the wave that is moving along the wall of the arteries. So that wave will bring about vibrations, and these vibrations are the ones that you are able to feel as a pulse, which is different from the movement of the blood within the cardiovascular system. Then you have the pulse rate. The pulse rate is described as a number of pulse wave formation per minute. So the number of these wave formation per minute, then you have your pulse rate. That's why we say that the pulse rate in most cases should be the same as the heart rate, but sometimes you find that the pulse rate and the heart rate are not the same. So you can have less pulse rates and more of the heartbeats. That will result into a dropped pulse. So the pulse rate and the heart rate are similar, but a difference between the two may also occur in case of a dropped pulse. The slower pulse is recorded than the heart rate in weak ventricular contractions, and this is referred to as cardiac insufficiency. So you can have cardiac insufficiency whereby the ventricles are not strong enough, they can't simulate the formation of the pressure pulse wave. So this pressure pulse wave sometimes can be absent. So you're talking of a dropped pulse. Okay, so the following diagram is just showing you how you can feel the pulse. So you can see here, as the heart is contracting, it's pushing blood into the aorta, and that will cause expansion of the aorta. And you know to say that the aorta is elastic. So you find that as it recoils back, there is expansion and recoiling of the aorta that will produce a wave. So this wave is called the pressure wave or pressure pulse wave. So you can see here that the wave is moving at a faster speed as compared to the movement of the blood. So the column of blood that is moving within the blood vessels is not as fast as the pressure pulse. So this will create the pulse that you are able to feel in the extremities at different actually, then you also have proceed. So the heartbeat is just a single pulsation of the heart, including one complete systole and diastole. So one complete systole and diastole is referred to as a heartbeat. You're talking of a single contraction and a single relaxation of the myocardium. So contraction is called systole, relaxation is referred to as diastole. So a complete cycle, you have a single contraction and single relaxation of the myocardium. So you can see in this picture here that you have a heartbeat, and these heartbeats, you have a single contraction and single relaxation. So if you count the heartbeat in 1 minute, you have the heart rate. So how many heartbeats do you have in 1 minute? Then you're looking at heart rate. So heart rate is simply the number of contractions or beats per minute. Then the cardiac cycle refers to the repeating pattern of contraction and relaxation of the heart. So the cardiac cycle is the performance of human heart from the ending of one heartbeat to the beginning of the next heartbeat. So from the ending of one heartbeat to the beginning of the next heartbeat, those events that are taking place there are referred to as the cardiac cycle. So cardiac cycle, these are just repeating pattern of contraction and relaxation of the heart. So with those terminologies, now we are good to look into the cardiac cycle and the heart sounds. So let's start. So like I said, the cardiac cycle refers to the repeating patterns of contraction and relaxation of the heart. And the phase of contraction is called systole, and the phase of relaxation is called diastole. So when these terms are used without reference to specific chambers, they refer to contraction and relaxation of the atria or the ventricles. So you can just have contraction of the atria or contraction of the ventricles, or relaxation of the atria or relaxation of the ventricles. So you're talking of systole and diastole. The atrial contraction occurs towards the end of diastole. So when the atria is contracting, it means that the ventricles are relaxing. So it means the atrial contraction is taking place at the end of ventricular diastole. So when the ventricles are relaxed, so when the ventricles contract during systole, the atria are relaxed. So you find that the atria can contract, the ventricles are relaxing. When the ventricles are contracting, the atria will relax. So you have that sequence whereby the atria are contracting and the ventricles are relaxing. When the ventricles are contracting, the atria are relaxing. So that's what that sentence means. So the heart has two-step pumping action. So you have the right and left atria contract almost simultaneously or almost at the same time, followed by the contraction of the right and left ventricles. And there's a time delay in between the contractions of about 0.1 to 0.2 seconds. So there's a time delay, and this time delay is as a result of the AV node delay, because we said that they are slow at firing action potentials. That will allow the atria to contract, and then later on the ventricles will contract. So the time in between that passes is about 0.1 to about 0.2 seconds. So during the time when both the atria and the ventricles are relaxed, the venous return of the blood fuels the atria. So when the atria are relaxed and the ventricles are relaxed, there's venous return that is returning to the atria. So there's just passive venous return to the atria. And the buildup of pressure that results causes the AV valves to open and blood to flow from the atria to the ventricles. So you have passive movement of blood from the atria to the ventricles. Not that the ventricles are contracting. The ventricles are relaxing, and also the atria are relaxing. So the atria are relaxed, the ventricles are relaxed. So there is passive movement of blood from the inferior and superior vena cava into the atria, and then from the atria into the ventricles. So you find that it has been estimated that the ventricles are about 80% filled with blood even before the atria contract. So this passive movement of blood will account for about 80% of blood that is moving into the ventricles. Then later on, the contraction of the atria will add about the final 20% of end diastolic volume, which is the total volume of blood in the ventricles at the end of diastole. So the end diastolic volume is the total volume in the ventricles at the end of diastole or at the end of relaxation. So we said 80% is passive movement of blood from the atria into the ventricles. This blood is coming from the vena cava, the inferior and superior vena cava. So passive movement of blood is about 80%. Then the remaining 20% of end diastolic volume is as a result of the activity of the atrial contraction. So the atria now, they are contracting, pushing the extra 20% into the ventricles. And then you have your total end diastolic volume. The contraction of the ventricles in systole then ejects about 2/3 of the blood they contain. So 2/3 of the end diastolic volume is ejected into the aorta where now the ventricles contract. So this amount of blood that is ejected into the aorta is called the stroke volume. So the stroke volume is the fraction of the end diastolic volume that is ejected into the aorta and the pulmonary trunk, if you want. So the ventricles then fill with blood during the next cycle. So after contraction, the ventricles will relax to fill with blood. So at an average cardiac rate of 75 beats per minute, each cycle lasts about 0.8 seconds. So this is just a normal duration of a single heartbeat. So a single heartbeat, you're talking of contraction and relaxation, will take about 0.8 seconds. So this 0.8 seconds is divided into two. We have contraction and relaxation, systole and diastole. So most of the time with the cardiac cycle, the heart is spending in diastole, the heart is relaxing. So about 0.5 seconds is spent in diastole, and the other 0.3 seconds is systole. So diastole, 0.5 seconds, then systole, 0.3 seconds. So that's the heart cycle, the heartbeat. So now we need to expand more on the heart cycle. So this heart cycle or heartbeat is divided into stages or phases. So you have 7 phases that you need to be able to explain. So these are describing the events of the cardiac cycle. So this cardiac cycle is composed of 7 phases, starting with the atrial system. So the atrial systole is the phase 1, which takes about 0.1 second. Then after the atrial systole, the next thing is the ventricular systole, the contraction of the ventricles. So the ventricular systole is also divided into 3 sub-phases. So you have phase 2, which is called the Isovorimetric ventricular contraction, then phase 3, rapid ventricular ejection, phase 4, reduced ventricular ejection. Then after the ventricles contract or after systole, then what will follow is diastole. The ventricles have to relax. So the ventricular diastole is also divided into 3 sub-phases, and these are the phase 5, which is called the Isovorometric ventricular relaxation, which is very fast, about 0.06 seconds. Then you have the rapid ventricular filling, and you have reduced ventricular filling. So these are the 7 phases of the cardiac cycle. Phase 1, arterial systole. Phase 2, isovorimetric ventricular contraction. Then phase 3, rapid ventricular ejection. Phase 4, which is called reduced ventricular ejection. Phase 5, isovorimetric ventricular relaxation. Then phase 6, rapid ventricular filling, and phase 7, which is called reduced ventricular filling. So these are the 7 steps or 7 phases that are involved in cardiac cycle. So you need to be able to explain each and every phase in detail. So it's basically the same information. So you can see that the cardiac cycle here is represented in form of a circle. So this circle, you have 2 here. You have the outer circle that is representing the activities of the ventricles, and then you have the inner circle that is representing the activities of the atria. So you have the ventricles and the atria. So you can see, starting from inside here, the atria, you can have atrial systole or contraction of the atria. Then you also have the atrial diastole or relaxation of the atria. Then outside here, you have the activities of the ventricles. So you have 2 activities. It's either the ventricles are relaxed and then you have ventricular diastole, or the ventricles are contracting, then that is referred to as ventricular systole. So you have contraction, relaxation. Just like the atria, you also have contraction and relaxation. So they are divided into 7 steps or 7 phases. You're talking of the cardiac cycle. So when you're describing the cardiac cycle, you should be able to describe the 7 phases of the cardiac cycle. So we said phase 1 is called the atrial systole. So you can see here the atrial systole. When the atria are contracting, the ventricles are relaxing. So towards the end of ventricular diastole, this is where you're going to have the atrial systole, which will take about 0.1 or 0.11 second. So this is called the atrial systole. This is phase 1, the atrial systole. Then phase 2, then the ventricles now are contracting. So instead of looking at the activity of the atria, you will now shift to the activities of the ventricles in the cardiac cycle. So the first one is the atrial systole, then is followed by a contraction. Contraction is divided into 3. So you have phase 2, which is referred to as isovolumetric ventricular contraction. Phase 3, rapid ventricular ejection. Phase 4, reduced ventricular ejection. Then after reduced ventricular ejection, it means that the ventricles now will start relaxing because they have contracted. So you have ejected blood into the aorta and the pulmonary trunk. So now the ventricles have to relax to fill with blood again. So after reduced ventricular ejection, you have now diastole starting here. So the diastole is also divided into 3 phases. So from phase 4, you are going to phase 5. So phase 5, you have isovorimetric ventricular relaxation. After that, you're going to have rapid ventricular filling. After rapid ventricular filling, you have reduced ventricular filling. Reduced ventricular filling as phase 7. So these are the 7 phases of the cardiac cycle. So I've said you should be able to explain each and every phase. So now starting with atrial systole, where you have the starting of the cardiac cycle. So like I said, the cardiac cycle will take about 0.8 seconds on average. If you have the heart rate of about 75 beats per minute, then it means each cycle is taking about 0.8 seconds. So this 0.8 seconds is divided into 7 phases. The first one is the atrial systole. So the atrial systole, a bit of information on the atrial systole, what is happening here, you know to say that the atria are contracting. So the atrial systole is also known as pre-systole or last rapid filling phase. So it's called the pre-systole, which means before the contraction of the ventricles. That's why it's also referred to as pre-systole, or it's also referred to as last rapid filling phase. So it's last rapid filling phase because the atria are contracting. So the movement of blood from the atria into the ventricles is also rapid because of that contraction. That will increase the atrial pressure. So you have the last rapid filling. So it is the last phase of ventricular diastole. So you know to say when the ventricles are relaxing, that's when you have the atrial system. So in this phase, the atrial contraction occurs which is due to the electrical activation of the atria. So you have the electrical activation of the atria that is brought about depolarization of the atria. If you remember, you have that P wave. So the P wave will result now into the contraction of the atria. So during this phase, about 10 to 20% of blood is forced from the atria into the ventricles, while about 80% of the blood flows directly to the atria without atrial contraction. So this simply means that 20%, about 10 to 20% of the end diastolic volume is facilitated by the atrial contraction. But the other 80% is just passive filling with the ventricles. So blood is just moving from the inferior superior vena cava into the right atria and also into the ventricles. Or it's moving from the pulmonary vein and then into the left atria, then into the left ventricle. So the movement, which is just passive, is about 80%. Then the contraction of the atria is adding about 20%. So the atrial contraction acts as a primer pump and pushes the remaining 20% of blood into the ventricles, like I've already explained. The clinical significance of atrial contraction or atrial systole. So the clinical significance, it is because of this reason when the atria fails, its dysfunction is unlikely to be noticed unless the person exercises, then clinical signs like shortness of breath occasionally develop. So what you need to know is that we are saying that 80% of the ventricular filling is passive without the activity of the atria. So if you have dysfunction of the atria, you will still have your 80% of filling of the ventricles. That will be just enough to maintain your conscience. So you find that when you have difficulties or you have diseases that are affecting the atria, it's very difficult for you to notice that. Not until you allow this patient to start exercising, that's when you can have shortness of breath. But before that, when a person is just resting, you won't see any clinical signs because the function, the contractility of the atria is only just adding about 20% of end diastolic volume. The atrial systole lasts for 0.11 seconds, like I've already stated. Then the heart sounds during atrial systole. So there are also heart sounds that you can hear during atrial systole. So the heart sounds that you're going to get here is the fourth heart sound, which is produced during atrial systole, and it's not audible in normal person, and it's only audible in ventricular hypertrophy. So when you have ventricular hypertrophy, you can get the fourth heart sound. I'll explain the first, second, and third heart sounds. But during this phase, you can get a fourth heart sound. And this is also audible in children, you know, but in adults, sometimes you cannot hear it. But just not to say that you have the fourth heart sound that is audible as a result of ventricular hypertrophy. So if you have ventricular hypertrophy, you can get a fourth heart sound. And mainly this is due to the vibrations that will set in the atria. As the atria are contracting, there are those vibrations that you get as a sound. So the fourth heart sound, it is produced during atrial systole and considered as physiologic heart sound. The characteristics of these fourth heart sounds, it is a short, low-pitched sound. Duration of the sound is about 0.02 to 0.04 seconds. So it's very short. Causes, it's due to vibrations which set in the atrial musculature. So like I said, when the atria are contracting, there are those vibrations. So those vibrations will be picked as the fourth heart sound. So this fourth heart sound, it coincides with the interval between the end of P wave and the onset of Q wave. So between the P wave and the onset of Q wave, you can see the fourth heart sound. Okay, so we proceed. That is atrial systole, and here you know to say that the atria is contracting at the 20%, the 80% of end diastolic volume is just passive. Then the contractility is just adding 20%, and then during atrial systole, you can also get the fourth heart sounds. That is due to vibration of the atria, and sometimes due to ventricular hypertrophy. So if you have hypertrophy of the ventricles, you are able to get a fourth heart sounds, because as blood is moving into the ventricles, they will start flashing against the hypertrophied ventricle walls, and then you'll be able to get the fourth heart sound. That's why we are saying it's also due to hypertrophy of the ventricles. Then the second phase, it's isovolumetric ventricular contraction. So isovolumetric ventricular contraction. Iso means the same. Volumetric, you're looking at the volume of blood that is moving into the ventricles. So isovolumetric ventricular contraction, you find that the volume of blood in the ventricles remains the same as the ventricles are contracting. That's why it's called isovolumetric ventricular contraction. So now let's look at isovolumetric ventricular contraction. So like I said, isovolumetric ventricular contraction is the first phase of ventricular systole. So the isovolumetric ventricular contraction is the first phase of ventricular systole, meaning that it's a first phase during the contraction of the ventricles. So it is also called the isometric contraction, which is characterized by an increase in the muscle tension without any change in the length of muscle fibers. So the isovolumetric ventricular contraction is also referred to as isometric contraction. So from the word itself, isometric, meaning that the length of the muscle fibers are the same, but there is development in tension. So this is because when the ventricles are contracting, it will result into the closure of the AV valves, but the semilunar valves are not yet open. So during this contraction, you find that there is an increase in the pressure, but the volume of blood within the ventricles remain the same. That's why it's also referred to as isovolumetric ventricular contraction. So during this phase, electrical activation of the ventricles occurs, and the ventricles begin to contract, and the following events occurs. So you have the ventricular pressure that will rise. So there is a rise in ventricular pressure, and it becomes greater than the atrial pressure. So because the ventricular pressure increases, then later on it will become greater than the atrial pressure. But just note to say that during isovolumetric ventricular contraction, both the AV valves and the semilunar valves are closed. So the AV valves are closed, it is because the pressure difference. So the pressure difference, you know to say that the ventricular pressure now is mounting, so it will become greater than the atrial pressure. That will result into the closing of the AV valves. Then the semilunar, aortic, and pulmonary valves do not open yet. So there is no emptying and no volume change. So because the AV valves, they have closed, but this ventricular pressure is not strong enough to open the semilunar valves. So you find that both the AV valves and the semilunar valves are closed when the atria, when the ventricles are contracting. So there is no change in the volume of the end diastolic volume, or there is no change in the volume within the ventricles, but the pressure is increasing. As all the valves are closed, the ventricles contract as closed cavities, and there is an increase in muscle tension. So the ventricular pressure rises. Isovolumetric ventricular contraction lasts for about 0.05 seconds. So what it means is that during isovolumetric contraction is taking place, you find that there is tension that is developing, but the volume remains the same. So on ECG, it is represented by the QRS complex. So isovolumetric contraction, when now the ventricles are contracting, but there is no change in the volume of blood, and there is an increase in pressure, that is represented by the QRS complex, because after the QRS complex, you know to say that you're going to have the contraction of the ventricles. QRS complex is as a result of depolarization of the septum, the major ventricles, and the base of the ventricles. So after depolarization, you have a contraction that is followed there. Then you have the heart sound during isometric ventricular contraction. So during this, you're going to hear the first heart sound. So the closure of the valves result into the first heart sound, which is called the lab or the lap-dap sound. So the normal heart sounds, you have the lap-dap, the first and the second heart sounds will give you the lap-dap. So the lab or the lap-dap is referred to as the first heart sound. So it's due to the closure of the mitral valves and the tricuspid valves, or the AV valves. So the closure of the AV valves will give you the first heart sound. But you need to know that the mitral valves closes before the tricuspid valves. So the first ones that are closing are the mitral valves or the bicuspid valve, then followed by the tricuspid valve. So because of that, you can have splitting of the first heart sound, because you know to say that the first ones that are going to close are bicuspid valves on the left part of the heart, then followed by the tricuspid valves. So sometimes you can have splitting of the first heart sound. So the first heart sound, it is produced during the isometric contraction and area part of ejection period. It resembles spoken word, lab, or the lap-dap, like I've already explained. Characteristics, it is a long, soft, low-pitched sound. Duration is between 0.1 to about 0.17 seconds. So it's a long, soft, low-pitched sound, the lab. The causes mainly is due to the sudden closure of atrioventricular valves, like I said. Then the first heart sound on the ECG, it coincides with the peak of the R wave. Remember, the R wave is due to depolarization of the major ventricles. So as you are having the depolarization of the major ventricles, this is where you're going to get the first heart sound, because the pressure now is so much that it's greater than the atrial pressure, then that will bring about closure of the AV valves. The atrioventricular valves are going to close. So like I said, the bicuspid valves will close first, then followed by the tricuspid valve. But there is no much difference in terms of time. So you just get the same prolonged sound, which is called the lab. And then you have the lap-dap sound. So when you play this illustration here, you'll be able to get the sound, the lap-dap sound. Okay, so you can see in this illustration, the closure of the AV valves will bring about the lab sound. Then the closure of the semilunar valves that we'll discuss later on will bring about second heart sound, which is called the dap. So you have the lap-dap sound. So what is the clinical significance of isometric ventricular contraction? So you know to say that during isometric ventricular contraction, as explained above, the pressure increases in the ventricles during an isovolumetric ventricular contraction when the pressure increases above the pressure in the pulmonary artery in the aorta, the semilunar valves will open. So now what you need to know is that when you're having the isovolumetric ventricular contraction, there's an increase in the ventricular pressure. So this increase in ventricular pressure will now force the opening of the semilunar valves, and then later on move into the ejection fraction or the ejection phase of cardiac cycle. So the ejection phase of a cardiac cycle is as a result of opening of the semilunar valve. So blood now is able to move from the left ventricle into the aorta, from the right ventricle into the pulmonary trunk because of the opening of the semilunar valve. So now we'll move into rapid ventricular ejection, or the ejection phase of the cardiac cycle, phase 3. So we are starting with rapid ventricular ejection. So in rapid ventricular ejection, as a result of isotonic contraction of the ventricles and the opening of the semilunar valves, blood is ejected out of the both ventricles. So you know to say now, because the pressure has increased so much, that will result into pushing open the semilunar valves. Then when the semilunar valves opens, blood is ejected into the aorta and the pulmonary trunk. So during this phase, the ventricular pressure rises to its maximum value, that is above 80 millimeter of mercury in the left ventricle and slightly above 8 millimeter of mercury in the right ventricle. So you know to say that as the ventricles are contracting, the ventricular pressure is increasing. So when you're looking at the left ventricle, the pressure will rise above 80 millimeter of mercury. And when you're looking at blood pressure, you have systolic blood pressure and diastolic blood pressure. The systolic blood pressure, the maximum can go is 120. The diastolic blood pressure is 80. So it means that the pressure in the aorta, it's 80, but the pressure in the ventricles is now rising above 80. So that will cause the opening of the semilunar valves. So in the left part of the heart, it will raise to above 80 millimeter of mercury, but in the right part of the heart, you know to say this is low blood pressure system. So find that it will raise above 8 millimeter of mercury. And then those semilunar valves, the pulmonary trunk semilunar valves are going to open. Then you have now your rapid ejection phase. So this pressure push aortic and pulmonary valve open, and blood empties into the aorta and the pulmonary trunk. Hence, this period is referred to as ejection period. So ejection period because blood now is ejected into the aorta and the pulmonary trunk. The duration is about 0.22 seconds. So it is further divided into two phases. You have the first one is referred to as rapid ventricular ejection, and the second one is reduced ventricular ejection. So the ejection period of the cardiac cycle is divided into the rapid ventricular ejection and the reduced ventricular ejection. So the first one that we're discussing is the rapid ventricular ejection. So during the rapid ventricular ejection phase, it starts immediately after the opening of the semilunar valves because now blood is being ejected. So during this stage, a large amount of blood is rapidly ejected from the both ventricles into the aorta and pulmonary trunk. Then it is the first 1/3 phase in ejection period. During this, about 70% emptying occurs. So 70% of emptying is taking place during rapid ventricular ejection. So it lasts about 0.13 seconds. So the actual rapid ventricular ejection phase, it will last for about 0.13 seconds. So during the period of rapid ventricular ejection, the ventricular volume decreases because most of the stroke volume is ejected during this phase. So it means that now the stroke volume is being ejected into the aorta, and then you realize to say that the ventricular volume will start decreasing because you're losing blood into the aorta, or you're pushing blood into the aorta or the pulmonary trunk. Then after rapid ventricular ejection, we have reduced ventricular ejection. So a bit of information on reduced ventricular ejection. So in this phase, ejection of blood from the ventricles continues, but it is slower. It results in a decrease of ventricular pressure. So the ventricular pressure will start reducing. So it will bring about reduced ventricular ejection. So it is the last two-third phase in ejection period. During this phase, about 30% emptying occurs. So now 70 plus 30 will give you the total 100 ejection, 100% ejection period. So during this phase, blood runoff from the large arteries to small arteries. So you find that the aortic pressure also decreases because now blood is moving from larger arteries to the smaller arteries. So the aortic pressure will start reducing as well. The duration of this is about 0.09 seconds. So if you add 0.09 plus 0.13 to give you the overall ejection period, which is about 0.22 seconds. The atrial filling begins and the onset of the T wave on the ECG, which represents the polarization of the ventricles. So after reduced ventricular ejection, the ventricles will have to relax. But for the ventricles to relax, first you need to appreciate the polarization of the ventricle. That is represented on the ECG by a T wave. So the T wave on the ECG will represent the polarization of the ventricles that will be followed by relaxation of the ventricles. So we have the proto-diastole. The proto-diastole indicates the end of systole and the beginning of diastole. So the end of contraction and the beginning of relaxation, that period is called the proto-diastole. It's before the relaxation. That's why it's referred to as proto-diastole. So like I said, this proto-diastole indicates the end of systole and the beginning of diastole. Pro means first and diastole means relaxation. So it is the first stage of ventricular diastole, or the first stage of ventricular relaxation, if you want. So as the blood is ejected from the ventricles to the aorta and pulmonary artery, the pressure develops in the pulmonary artery and aorta, and the pressure drops in the ventricles. Because of that, it will result into the closure of the semilunar valves. So when the intraventricular pressure drops less than the pressure in the aorta and the pulmonary artery, the semilunar valves are now going to close. So the atrioventricular valves are already closed. No other change occurs in the heart during this period. The proto-diastole lasts for about 0.04 seconds. So the closure of the semilunar valves will result into the second heart sound. So the second heart sound is produced due to the closure of the semilunar valves during the proto-diastole. So remember, diastole is also divided into 3 stages. So we have the isovorometric ventricular relaxation being the first one. So the isovorometric ventricular relaxation, it means that the volume within the ventricles is maintained the same, but there is reduction in the pressure within the ventricles. So that stage is referred to as isovorometric ventricular relaxation. So a bit of information. That is phase 5, the period of isovorometric ventricular relaxation. So the isometric relaxation is characterized by a decrease in the tension without any change in the length of muscle fibers. So it's called isometric relaxation, meaning that the length of the muscle fibers remain the same. That's why it's called isometric, but there's a decrease in the tension. So there's a decrease in the pressure, but the length of the muscle fibers remain the same. So this period is referred to as isovorometric ventricular relaxation, which is taking place at the end of the T waves after repolarization of the ventricles. The ventricles will start relaxing. So the first stage there, it's called isovorometric ventricular relaxation. So the pressure drops results in aortic valve closure, followed by the closure of the pulmonary valves. So again here, the aortic valves will be the first one to close, then followed by the pulmonary valves. So the second heart sound can also split. So there is splitting on the second heart sound. That is due to inspiration, which delays the closure of the pulmonary valve. So during inspiration, there is closure, there is delayed closure of the pulmonary valve. That will result into splitting of the second heart sound. So as all the valves are closed in this phase, the ventricular volume is constant. That is why this phase is referred to as Isovolumetric phase. So the volume remains constant because both the AV and the semilunar valves are now closed. So in as much as the ventricles are relaxing, but there is no feeling of blood into the ventricles. So the volume remains the same. So that's why it's referred to as Isovolumetric ventricular relaxation. So during this phase, we say that the semilunar valves are going to close and then to bring about the second heart sound. So this second heart sound, it produces during the onset of diastole. So it represents, or it resembles the spoken word, the dub. So you have now the complete lap dub sound. So you can see here, you'll be able to listen to the lap dub sound as you are using your stethoscope, because the first heart sound is due to the closure of the AV valves, the lab. Then the second heart sound is due to the closure of the semilunar valve, the dub. So you have the lap dub sound, lap dub sound. So the causes of the second heart sound is mainly due to the closure of the semilunar valves, the aortic and the pulmonary valves. So this second heart sound on the ECG, it will coincide with the T wave on the ECG. So we said the T wave is the one that is responsible for repolarization of the ventricles. So after repolarization of the ventricles, you have relaxation of the ventricles. So the first part of relaxation is the isovorometric relaxation. So this isovorometric relaxation will bring about closure of the semilunar valves, the second heart sound. Then because sometimes you have delay in the closure of the pulmonary semilunar valves, that will bring about splitting of the second heart sound. But just not to say that the second heart sound is a short, sharp, and high-pitched sound. So it's a very short, sharp, high-pitched sound, which is different from the from the first heart sound, which is a long, and it's not sharp, it's low-pitched sound. But here, the second heart sound is a short, sharp, high-pitched sound that is produced due to the closure of the semilunar valves. On the ECG, you will see it after the T wave. The T wave repolarization of the ventricles will relax, and then to bring about the period of isovolumetric ventricular relaxation. The significance of isovolumetric ventricular relaxation here, mainly it will bring about the closure of the semilunar valves and also later on the opening of the AV valves. So just not to say that within the ventricles the pressure is reducing. Because the pressure is reducing, then the atrial pressure will increase more than the ventricular pressure. That will force the opening of the AV valve. So the tricuspid valve and the bicuspid valve will open soon after the isovolumetric ventricular relaxation. Then you have now rapid ventricular filling. So after the opening of the AV valves, so the opening of the AV valves are taking place here just after the isovolumetric ventricular relaxation. You have the opening of the AV valve that will bring about the rapid ventricular filling. So the ventricles will start filling now. You have that passive 80%. Then later on, due to the contraction of the atria, you have the addition of the 20%. So now during the rapid ventricular filling, what happens? And before we look at the rapid ventricular filling, because we've discussed the first two normal heart sounds, the first and the second, we've already discussed the fourth, but never mind about that, because sometimes you might not get it. So the first we said it's because due to closure of the AV valve. The second is due to closure of the semilunar valves. So within the body, you have landmarks where you're supposed to put your stethoscope for you to listen to the heart sounds. So within the heart, you can see the location of the the valves that are responsible for production of those heart sounds. So you have the tricuspid valves and the mitral valve, which is also called the bicuspid valve, that are between the atria and the ventricles, and between the ventricles and the aorta and the pulmonary trunk, you have the semilunar valve. So you have the aortic valve and the pulmonary valve. So the first heart sounds is due to the closure of the AV valves. So the first one that will close is the mitral valve, because you know to say that the left part of the heart is stronger as compared to the first part of, as compared to the right part of the heart. So you find that they will be the first ones to close because of the greater force, and then later on you have the closure of the tricuspid valve. So sometimes you can have splitting of the first heart sound, like we said. So the first one is due to the closure of the mitral valve. So where can you place your stethoscope for you to listen to the closure of the mitral valve? It's within the fifth intercostal space. So you can see here the fifth intercostal space. So the landmarks, you have the sternal notch. You palpate for the sternal notch, then the angle of the wheel or the sternal angle, then you palpate for the first intercostal space, second, third, fourth, and fifth intercostal space. Mid clavicular line, this is where you put your stethoscope, and then you'll be able to get the closure of the mitral valve. So it means when you put your stethoscope here, the mitral valve is held during S1. Then if you put your stethoscope in the fifth intercostal space, but left sternal border, just on the left part of the sternum, so you can see here the sternum is somewhere here, but on the left sternal border of the sternum in the fifth intercostal space, this is where you're going to hear the closure of the tricuspid valve. So the closing is almost simultaneously, so you find that you just get the first heart sound as the lab, then later on the dab, due to the closure of the semilunar valves. So the closure of the semilunar valves, where you're going to place your stethoscope, the diaphragm of the stethoscope. So you can see here that you have these locations. So the closure of the semilunar valves, you can listen to the closure of the semilunar valves by putting the stethoscope on the second intercostal space. So the first one that will close is the aortic valve. So the aortic valve, you can place your stethoscope in the second intercostal space, right sternal border. So on the right side of the sternum, this is where you put, and then you'll be able to get the closure of the aortic valve. And then again, within the second intercostal space, but now on the left sternal border or the sternum, this is where you can get the closure of the pulmonary valve. So you have the lap dap sound. So with that information, we proceed by looking at the rapid ventricular filling. So we speed up. Rapid ventricular filling, so you have the period of rapid ventricular filling. During this phase, the following changes occur. So you have the ventricles pressure decreases because now they're relaxing. And when it gets less than the atrial pressure, the mitral valves open. So you have the mitral valves and the tricuspid valves that are opening. That will bring about passive filling of the ventricles. So with the opening of the mitral valves, the ventricular filling from the atrium begins. There is a sudden rush of blood from the atria into the ventricles. That is why this is called the rapid ventricular filling phase. So there's a sudden rush. Once there's opening of those mitral valves and also tricuspid valves, there is a rapid filling of the ventricles. This is where the name rapid ventricular filling comes from. Not that the atria, they are contracting, no, but there's just rapid filling, which is passive. So about 80% of feeding takes place during the rapid ventricular filling phase. So this phase will last about 0.01 seconds. Then the third heart sound can be heard here. So the third heart sound, as blood flows rapidly from the atria into the ventricles, it causes the third heart sound. which is normal in children, but in adults is associated with disease. So in children, you find that it's normal to get the third heart sound. That is due to rapid ventricular filling. So as this blood is rushing into the ventricles, then that splashing sounds you're going to hear as the third heart sound, which is normal in children. But in adults, if you're getting the third heart sounds, it's associated with a disease. So third heart sounds, it is produced during rapid filling period of the cardiac cycle. Characteristics, it is short and low pitched sound. Duration is about 0.07 to about 0.1 seconds. Causes, it is produced due to the vibrations which set up in the ventricular wall. So vibration of the ventricular wall due to the rushing of blood into the ventricles. So during rapid filling phase. So during rapid filling phase, you have now vibration that will set within the ventricles as they are receiving blood. So it's very rapid. And then you have the vibration of the ventricles that will bring about the third heart sound. So it's normal in children, but if you hear it in adults, then that can be associated with disease. So the third heart sound on ECG, it appears between the T and the P wave. So you know to say T wave, it's repolarization of the ventricles that will bring about relaxation of the ventricles. The T wave will bring about contraction of the atria. So in between there, you have the third heart sound that is due to rapid filling of the ventricles. So now we have all the four heart sounds, the first, second, third, and fourth that we've already explained. So the third heart sound is during the rapid ventricular filling. Then after that, we move to reduced ventricular filling, which is responsible for about 30% of ventricular filling. So the rapid, we said, is responsible for 70%. Then we have period of reduced ventricular filling, which is responsible for 30% of ventricular filling. So it is the shortest phase of the cardiac cycle. During this phase, the ventricular filling continues, but it is at a slower rate. So the rate is very slow. So this phase is called diastasis. So it's also called diastasis. So the time required for diastasis and ventricular filling depends upon the heart rate. So different heart rates will result into reduction in this period. So sometimes if you have an increase in heart rate, you find that this period will be reduced. If you have a decrease in heart rate, it means that this period is elongated. So for example, increase in heart rate cause decreased time available for ventricular filling and decreased end diastolic volume and also a decreased stroke volume. That makes sense. Then we have the rapid filling phase. So in rapid filling phase, then you are going back to atrial contraction. So the rapid filling phase is basically the first phase of the cardiac cycle. So the cycle repeats itself over and over. So this phase occurs because of the atrial contraction, as we've already discussed. So after reduced ventricular filling, after reduced ventricular filling phase, the atria contracts and pushes a small amount of blood into the ventricles. And during this phase, about 10 to 20% of ventricular filling takes place. And then this 10 to 20% due to the contraction of the atria is also referred to as atrial kick. Atrial kick is as a result of the contraction of the atria. Okay, so this is just a table that is summarizing the phases of the cardiac cycle related to the ECG tracing. So you can see here you have the cardiac cycle on top, then down here you have the ECG tracing. So the first one, you have the atrial systole that begins, or the atrial contraction. When you have the atrial contraction, you have that 20% of blood that is pushed into the ventricle. Remember, the 80% is due to passive flow of blood from the atria into the ventricle. So you have the passive ventricular filling, which is 80%. Then the active ventricular filling is as a result of the atrial systole, the contraction of the atria that will push blood into the ventricles, the 20%. So before you appreciate the atrial systole, you can see here you have the P wave. After the P wave, depolarization of the atria that will bring about contraction of the atria on the ECG. Then after that, there's a period of a delay. So that period of delay, it will allow now blood to move from the atria all the way into the ventricles. So you have the PR interval or the PR segment here, or PQ segment or PR segment, where you have a delay at the AV node. Then the action potentials later on will move to the ventricles. So you have depolarization of the ventricles that will bring about QRS complex. After depolarization of the ventricles, you have now ventricular systole that will bring about contraction of the ventricles after stimulation by the QRS complex. So the ventricles now, myocardium and the ventricles are stimulated, so they are going to contract. So you have the first stage of contraction, you have ventricular contraction that is going to push the AV valve close. So as the AV valves are closing, you're going to get the first heart sound. Remember, during ventricular filling here, you have the fourth heart sounds that you can get. Sometimes it's due to the hypertrophy of the ventricles, like I've already explained. The first heart sound is due to the closure of the AV valve that is taking place within the ventricular systole. Then after that, the pressure will be so much. So before the semilunar valves open, you're going to have isovolumetric ventricular contraction, whereby the ventricles are contracting, but there is no change in the volume of blood in the ventricles. Then after that, you're going to have pressure mounting that is greater than the aortic pressure or the pulmonary pressure. That will push open the semilunar valves, and then you have rapid ejection period. So you have the ventricular systole, the second phase here, the semilunar valves are open and blood is ejected into the aorta and the pulmonary trunk. Then after that, you have diastole taking place, relaxation of the ventricles. So you have isovolumetric diastole taking place first. So you know to say that the pressure in the ventricles is reducing. As the pressure is reducing, you find that the atrial pressure or the pulmonary trunk pressure will be more than the ventricular pressure. That will push the semilunar valve to close. So the semilunar valves are closed, but the AV valves at this point are not yet open. So you have the isovorimetric relaxation of the ventricles. After that, now, the pressure in the atria will be more than the pressure in the ventricles that will push open the AV valve. The tricuspid valve and the bicuspid valves are going to open to allow rapid filling of the ventricles. So you have the rapid ventricular filling taking place. Then later on, you have the slow or reduced ventricular filling. Then after that, you have the atrial systole or contraction. You go back again. So you can see on the ECG, when the ventricles are contracting, after contraction of the ventricles, for you to have relaxation of the ventricles, you have repolarization of the ventricles, and then the ventricles will start relaxing. So this is just a summary of the cardiac cycle. Okay, after that, now let's look at the Uyghurs diagram. So the Uyghurs diagram. So this is the last part of our lecture. So it will take about 5 or less minutes for me to discuss this. So now let's start by looking at the Uyghurs diagram. So like I said, the Uyghurs diagram, it was a diagram that was discussed by a scientist by the name of Carl John Uyghurs. So this is the scientist that described the relationship between the pressure in different ventricles and also the pressure in the aorta and pulmonary trunk, and also by looking at the ECG. So these scientists' illustration of coordinated events makes it easier to correlate the changes during the cardiac cycle. So there are a lot of events that are taking place there. So John Uyghurs is the one that illustrated the relationship between events that are taking place within the heart and the ECG. So he plotted a plot whereby the x-axis was used as time, and the y-axis, it contains a lot of things. So within this plot, you have the x-axis where you have time. Then the y-axis has got a lot of things to relate a lot of these things that are taking place within the heart. So within the x-axis, you have time. Y-axis, you have a lot of things. So you have blood pressure. This blood pressure in the you have aortic pressure, you have ventricular pressure, you have arterial pressure. So this is blood pressure, aortic blood pressure, ventricular blood pressure, and arterial blood pressure on the y-axis. On top of that, you can also put the ventricular volume. Then you also have electrocardiogram, the ECG itself. Then the other things are optional. You can also include the arterial flow and also the heart sounds. So this is called the Uyghurs Diagram. So this Uyghurs Diagram is summarized in this table or this diagram. So you can see here that there are a lot of things. So like I said, the x-axis, you have time. Then the y-axis, you have a lot of things here. So you can see in the x-axis here, you have time, and then this time, it's also describing the cardiac cycle. So the different stages of the cardiac cycle or phases of cardiac cycle. Phase 1, 2, 3, 4, 5, 6, up to 7, and then it will repeat itself. It will start again, phase 1, 2, 3, 4, up to 7. So down here you have time that is represented by the cardiac cycle. Then on y-axis, you have a lot of things. You have aortic pressure, you have arterial pressure, you have ventricular pressure, then you have ventricular volume, the electrocardiogram, and phonocardiogram. Phonocardiogram is looking at the heart sounds. So let's start. So let's look at the atria and the ventricles from the start all the way to another heartbeat. So you can see here that there are these activities that are taking place here that is plotted against time. So in phase 1, we said it's atrial contraction. But before the atria contracts, remember that the atria were relaxing. So during atrial contraction is as a result of the P wave. So you can see here on the ECG, you have the P wave that will bring about depolarization of the atria, and then the atria will contract. Then you have this phase 1, which is called atrial contraction. When the atria are contracting, with regard to the atrial pressure, you know to say that before atrial contraction, the atrial pressure is low, it's almost 0. But later on, you have the venous return that will increase the pressure within the atria before the atria contracts. So you find that the atrial pressure will start increasing because of venous return. Then after stimulation, it's going to contract, so the atrial pressure are going to increase. After increasing of the atrial pressure, you know to say you are pushing that 20% of blood into the ventricles, the 80% is passive. So when the ventricles are relaxing, the atria are also relaxing. There is passive movement of blood from the atria into the ventricles. So that will account for about 80%. The other 20% of end diastolic volume, we said, is as a result of the contractility of the atria. So the atrial contraction will result into an increase in atrial pressure that is also pushing blood into the ventricles, that 20%. Then after that, you have stage 2 or phase 2, which is referred to as isovolumetric contraction of the ventricles. So isovolumetric ventricular contraction. During isovolumetric contraction, you know to say that you have more of isometric contraction of the ventricular muscles. So there is tension that is developing in the muscles, but the length of the muscle fibers remain the same. Because of that, there is no change in the volume of the ventricles. So there is no change in the volume of the ventricles, but this pressure is high enough to close the semilunar valves. So you find that during isovolumetric contraction, the ventricular pressure is going to increase. So you can see here that the ventricular pressure is increasing. So as the ventricular pressure is increasing, it's going to increase more than the atrial pressure. That will result into the closing of the AV valves. So the AV valves are going to close here. And as the AV valves are closing, you're going to get the first heart sound. So on the phonocardiogram, you can see that you can get the first heart sound, which is long, low pitch, sound. This is a lab sound. Then it will be followed by DAP later on. So the lab sound is as a result of the closure of the AV valve, as a result of the buildup of pressure in the ventricle. So you can see the ventricular pressure here within the isovolumetric contraction. There's an increase in the ventricular pressure that will cause the closing of the AV valves. Then later on, this pressure will be more than the aortic pressure. It will be more than 80 millimeter of mercury in the left ventricle, and then it will be more than 8 millimeter of mercury in the right ventricle. That will now become more as compared to the pressure in the aorta and the pulmonary trunk. So because of that, it's going to force the opening of the semilunar valves. So you can see here at the end of the isovolumetric contraction, you have the opening of the aortic valves. These are semilunar valves. So aortic valve and also the pulmonary valve is going to open. So the opening of these semilunar valves will now bring about the third phase of cardiac cycle, which is referred to as rapid ventricular ejection. So you have rapid ventricular ejection phase that is brought about by the opening of the semilunar valves. So now blood is being ejected into the aorta and also into the pulmonary trunk. So the opening of the aortic valve and the semilunar valve, you will know to say that the ventricular pressure is still increasing because the ventricles are still contracting. So because the ventricles are contracting, the ventricular pressure you can still see here is still increasing. That will result into ejection of blood into the aorta and the pulmonary trunk. But now when you are looking at the aortic pressure here, this line here is indicating the aortic pressure. You can see during diastole here and during isovolumetric contraction, the aortic pressure is reducing because this is during diastole. So when the semilunar valves open, initially the aortic pressure can be 80 millimeter of mercury, but when the semilunar valves open, the pressure in the aorta is going to increase to become more than 80 because now the pressure that is coming from the ventricles is being pushed now into the aorta. So you can see that the aortic pressure is also increasing after the opening of the aortic valve or after the opening of the semilunar valve. So you can see that there's an increase in the aortic pressure as well. That is taking place within the rapid ejection phase. Then after the rapid ejection phase, you move to reduced ejection phase. So reduced ventricular ejection phase, it means that the muscles now will start relaxing to some extent. So not all the muscle fibers will relax at the same time. So you find that some they're still contracting. So you find that blood is still moving from the ventricles to the aorta or to the pulmonary trunk, but the ejection now will reduce. So we said during rapid ejection period, about 70% of blood is being ejected. Then during the slow ejection phase, about 30% is being ejected. So because of that, you can see that the ventricular pressure now will start reducing here. When the ventricular pressure is reducing, also the aortic pressure will start reducing here. You can see that. So when the ventricular pressure is reducing, the aortic pressure is also reducing. But what you need to know is that the aortic pressure is going to be maintained. Why? It's because during ejection phase, you have blood that is moving to the aorta, and the aorta is elastic blood vessel, so it's going to expand. And when ventricular pressure is reducing, you find that it's going to recoil. So the recoiling of the ventricles is also going to increase the aortic pressure. So you find that the aortic pressure is increasing, is still increasing, but the ventricular pressure is reducing. So that will cause backflow of blood. So this backflow of blood from the aorta into the left ventricle is going to be prevented by the closing of the aortic valve. So you can see here, when the ventricles are relaxing here. There is a closure of the aortic valve. So the closure of the aortic valve will result into the isovorimetric relaxation. So the isovorimetric relaxation, it means that the AV valve have closed. And the same, the closure of the aortic valve here, it means that the AV valve are already closed here. So there is no change in the volume of the ventricles as the ventricles are relaxing, because the aortic valve or the semilunar valves, they have now closed, and the AV valve were closed a long time. So you find that the volume will still remain the same as the ventricles are relaxing. So this stage is referred to as isovolumetric relaxation or phase 5. So you know to say that this phase 5 will start when the aortic valve closes or the semilunar valve closes. And the closure of the semilunar valve will result into second heart sound. So the closure of the semilunar valves will result into the second heart sound within the phonocardiogram. So within the phonocardiogram, you can see the second heart sound, which is very short, high-pitched sound. Short, high-pitched sound. So this is the dap sound. So the first one, lap, the second one, dap, lap, dap sound. Then at the same time, you can see here the pressure that is taking place within the atria. So we said within the atria during atrial contraction or systole, there's an increase in the pressure. Then the closure of the semilunar valve will bring about an increase again within the atrial pressure. So this wave within the atrial pressure. So you have the first wave that is as a result of atrial contraction is called the Airwave. So you can see the Airwave is as a result of the contraction of the atria after the P wave. So you can see here, then there will be closure of the AV valve due to an increase in the ventricular pressure because the ventricles now are contracting. So the AV valve are going to close. And this closure of the AV valve will produce a wave within the atrial pressure, which is called the C wave. So you can see here, you have this C wave that is taking place within the isovolumetric contraction and is as a result of the bulging of the valves. So as the AV valve are closing, they will bulge into the atria. So the bulging of the AV valve into the atria, but they'll be pulled by the chorda tendineae fibers. Then these chorda tendineae are connected to the papillary muscles. So you find that as they are closing, they'll close and then they will bulge into the atria. As they are bulging into the atria, they will produce a wave, which is called the C wave. This is the C wave you're seeing here. So after they close, you find that the atrial pressure will now reduce. Then you have also passive movement of blood. And that passive movement of blood, they have passive filling of blood into the atria, and they need to bring about the V wave. So the V wave is as a result of the passive filling of the atria. So this passive filling of atria, it will result into an increase in atrial pressure, creating the V wave. Then after the V wave, we have passive filling of the ventricles, and then it goes back into the contraction of the atria, producing the airway. So that's the atrial pressure. Then the ventricular volume down here. So you can see the ventricular volume down here during the atrial systole. You know to say that before the atrial systole, you have 80% of blood that is moving to the ventricles passively. So the passive movement of blood from the atria into the ventricles. Then later on, you have the atrial contraction or systole that will add the 20%. So when you're looking at the ventricles, you can appreciate the increase in the ventricular volume until such a time when you have isovolumetric contraction of the ventricles that will bring about closure of the AV valve. Once you have closure of the AV valve, it means that the AV valves are now closed and the semilunar valves are also closed. And then you have the isovolumetric contraction in which there is no change in the volume of the ventricles. So the blood in the ventricles is not increasing, is not reducing because all the valves here are closed. Then you have the isovolumetric contraction in which there is change in tension, but the volume remains the same. or there is an increase in tension, but the length of the muscle fibers remain the same. So you can see here you have just a straight line with regard to the ventricular volume. There's no change. So this is called isovorometric contraction. After that, the pressure in the ventricles will increase so much that it will become greater than the pressure in the aorta and also in the pulmonary trunk. That will force the opening of the aortic valve and the pulmonary valve. So the semilunar valves are going to open. When the semilunar valves are opening, you have the rapid ejection. So the rapid ejection, it means you're losing blood now into the aorta, or you're pumping blood into the aorta and the pulmonary trunk. So you can see the ventricular volume will start reducing here because blood is being pumped into the aorta and also into the pulmonary trunk. So you have the rapid ventricular ejection, then you have reduced ventricular ejection. So during rapid ventricular ejection, about 70% of blood is ejected. Then later on, during the reduced ventricular ejection, you have 30% of blood being ejected. Then you have the total 100% of the stroke volume that has been ejected into the aorta or the pulmonary trunk. Then after that, you find that the pressure within the ventricles will start reducing as the ventricles will begin to relax. So you know to say it will reduce less than 80 millimeter of mercury. When it reduces less than that in the left ventricle, then the aortic valve is going to close because the pressure within the aorta, it's more than the pressure in the ventricles. That will force blood will want to go back to the ventricles, so that backflow of blood is prevented by the closure of the aortic valve or the closure of the pulmonary valves. So when they close the semilunar valves, they will produce a sound. This is the second heart sound that is produced here. And then you can see here that this is followed by a T wave. A T wave is the one that is responsible for repolarization of the ventricles, and then you have relaxation of the ventricles. So because the semilunar valves are closed and the AV valves are also closed, you have no change in the volume of the ventricles. So this is called Isovorimetric relaxation of the ventricles. There is no change in the volume, but the ventricles are relaxing. Then after that, you go to phase 6, which is called a rapid filling phase. So you find that the atria now, there is no more venous return to the atria, and then the atrial pressure will start increasing, and then that was going to force the opening of the AV valve. So you can see here that there's an increase in the atrial pressure that will cause the opening of the AV valves. Then the ventricular volume will start increasing as blood is moving from the atria into the ventricles. So you have the rapid ejection phase, then, rapid filling phase, then later on you have reduced filling phase. So during rapid, about 80% of blood is moving into the ventricles, and then you have reduced filling phase about 10%. So here it's about 70%, here about 10%. Then after that, you have the atrial contraction that will add the other 20%. So you can see that the ventricular volume is still increasing to such a time when the AV valves are going to close. Once the AV valve are going to close, there's no change in volume, so it becomes a straight line. Then to bring about isovorimetric contraction of the ventricle. So the AV valve are closed, then also the semilunar valves are closed. There's no change in volume. And then when the pressure increases so much, there's opening of the semilunar valves or the aortic valves. That will bring about ejection period, and then the aortic volume will start reducing again during another contraction. So this cycle will repeat itself. So you can see the correlation of a lot of pressures: aortic pressure, arterial pressure, ventricular pressure, and ventricular volume, and also electrocardiogram. Then you also have phonocardiogram that is plotted against time. So you can also appreciate the third heart sound here. So we say the third heart sound is heard during the rapid filling. So you can see during the rapid filling phase here, as blood is moving from the ventricles into the, as it is moving from the atria into the ventricles, that feeling of blood, you find that sometimes it can hit the ventricles. So the splashing sound that is hitting the ventricles will bring about vibration of the ventricles, then that can produce the third heart sound. So you can have the third heart sound here. Then sometimes we said you can have the fourth heart sound, which is not shown here, but it will be somewhere here during the atrial contraction. So during atrial contraction, you can hear the fourth heart sound. Third heart sound is normal in children, but in adults can point to a disease. Fourth heart sound is mainly due to ventricular hypertrophy. So as the atria are contracting, that blood that is moving to the ventricles will cause vibration of the hypertrophied ventricles that will produce a fourth heart sound. So this is called the Uyghurs diagram. So the Uyghurs diagram is just showing you correlation of these blood pressures, different blood pressures with the ECG and also the phonocardiogram. So I hope you understand this. If not, I will still explain when we have the interactive lecture. So this is where I'm going to end this class. Thank you very much. So next time when we meet, we'll start looking at the cardiac output. So lecture 5, we'll discuss the cardiac output. But for now, this is where we're going to end. Thank you very much for your time.